Okay, so whenever you're ready, we're ready.
I just have this, oh, there it goes. Okay. So we were touching upon psychosocial issues in our patients with diabetes, and one thing I can't emphasize enough, and I know that all of us are not trained in social work, but I think that, if you don't evaluate the different barriers that people have in their environment, whether they have financial barriers to their insulin or their medications, or educational barriers or social barriers. I have some people that are homeless. So if we don't ask, we never know. And that really plays a huge impact in how we control every kind of disease and help patients. And it definitely has a huge impact on diabetes as well. And so I really always take the opportunity to ask about any of those issues that are impeding their care. And I refer them very frequently to psychosocial care, a psychiatrist or a psychologist. There's a new thing through the American Diabetes Association where you can actually type in a zip code and find an actual psychiatrist or a psychologist that you can find who specializes specifically in diabetes care, which I think is an amazing thing because diabetic patients definitely deal with stressors throughout their medical illness that are unique to diabetes and not other chronic medical conditions. There is a term that I think I've mentioned throughout these slides too that's called diabetes distress, and that means that the things that diabetic patients have to endure, checking their sugar sometimes 4 times a day, living with a disease that requires sometimes, insulin dependence if they're type 1, that can be very emotionally distressing. And so making sure that you're referring them so that they get the appropriate mental, social, emotional help they need to be able to care for themselves is a huge issue. And if that's not resolved or met, then they will never gain good control of their care because it really takes a sound mind for our patients to be able to want to care for themselves. So I can't stress this slide enough. You can go on to the next one, Kate. So again, there's that term that I was mentioning, the symptoms of diabetes distress, which, is just a term we use in specific to diabetes. So all the distress that comes along with, I'll just take 1 minute and let my colleagues here introduce themselves that just came into you guys.
Hi, I'm Renee Schwartfeger. I'm the nurse practitioner, one of the nurse practitioners in the clinic. Nice to see you all.
Hi, I'm Dr. Perini. I'm one of the endocrinologists. I'm excited to do this. So, hi.
So diabetes distress, again, it's something that I think we don't really pay much mind to if you're not the one that's checking your sugar and giving yourself, insulin injections 4 times a day, but really being cognizant of what our patients are experiencing and how much, anxiety and difficulty there is in managing this disease, considering even their work environment. Or school environment. I have a 17-year-old pregnant patient who has type 1 diabetes, and she comes to me crying and says she doesn't check her sugars. And then when I really ask her, why are you checking your sugars? What's the barrier? She tells me that she can't leave her class or her teacher doesn't allow her to leave her class in school. So, writing a letter to their teacher or writing a letter for them for their work environment is really important. Within the American Diabetes Association website, there's different laws that have been enacted that actually protect patients that have diabetes. And so in their workplace or in their place of education, they should always have appropriate breaks and time out to check their sugars and take snacks. And it shouldn't be a distressing thing for them. So as providers, if we need to help them and write letters, that's what we do all the time to try to help encourage compliance. You can go on to the next one, Kate. So this is the term that I mentioned, the distress that diabetes patients have. This is just the actual term that the ADA gives it. You can go on to the next one. So this is distinct from other psychological disorders. It's negative reactions or emotional burdens that these patients experience and having to manage a severe distressing disease daily. You can go along, Kate. I already mentioned that bottom bullet point. So, mentioning that there are psychologists and psychiatrists that deal specifically with diabetes is important. And I'd also like to make a point too that in type 1 diabetes specifically, a lot of patients have been shown in the data to have more mental illness, so more depression, anxiety, bipolar, and so making sure, patients with type 1 that we're also aware and alert, for those types of symptoms or those things as well. So you want to annually screen patients who are prescribed atypical antipsychotics for prediabetes or diabetes. If a second generation antipsychotic is prescribed for adults, changes in their weight, their glycemic control, cholesterol levels should be monitored, and their treatment regimen should be reassessed. So some antipsychotic medicines certainly can cause an increase in your blood sugar values. And I've even seen patients that come into our acute inpatient center who have been started on a new antipsychotic, and they're brand new, new diabetics, or sometimes even in DKA. So just be alert that some different medications for mental illness can cause increases in blood sugar. You can move on, Kate. So this is from the ADA itself, the table. So situations that warrant referral of patients with diabetes to a mental health provider. If their self-care remains impaired after they're having diabetes education. If they have depressive symptoms. So some of you may do I think it's called the PHQ-9. It's a screen for depression, and I think that's mainly in primary care clinics. I personally don't do the full questionnaire here in my clinic, but I definitely do try to screen for depressive type symptoms or suicidal ideation or homicidal ideation. But if you're using that screening tool, great. If you're not, just overall asking about SI or HI ideations in your clinic. If you do see that they have symptoms or suspicions of disordered eating behavior or eating disorders, I see this a lot too. And it can be both sides. So anorexia, but also it can be compulsive eating, for comfort. Or I think I mentioned this to you guys a couple weeks ago. One of my cases was a type 1 young female who came in. She had seen 4 different endocrinologists, and she never took her basal insulin. And so I was saying to her, why don't you, what is the problem with taking your basal insulin? Why have you never done it? And come to find out, she was exercising like 3 to 4 hours a day. She was so scared of gaining weight. And every time she took basal insulin, she gained weight. And so she refused previously to take it. So we settled on taking 2 to 3 units to start of her basal insulin, because as you know, type 1 diabetic goes into DKA without basal insulin. So, we started at a very small dose, and that's not perfect, but, finding a starting point or asking them, have you seen a nutritionist or a psychiatrist to counsel them about their anorexia or fear of weight gain is also very important too. So we talked about mental illnesses in situations where they've had repeated DKA. They constantly are readmitted to the hospital. You really want to figure out, what are the barriers? Why are they coming back in DKA? Why are they not taking their insulin? And a lot of times, that again, those are behavioral things in their social life that we can't control. But unless we address them, we're really not going to make a difference in their care. And self-care behaviors, so an impaired ability to perform self-care. A lot of people that I have that have like neuropathies or retinopathies, I send them to diabetic educators. They really help with different strategies of checking their sugar. There's even new the Libre system. I don't know if you guys have heard about it, but people that I have that may have an inability, or maybe they have some kind of severe neuropathy or retinopathy or some cognitive inabilities. There's this Libre that it's a CGM, a continuous glucose monitor, and you put the reader on under your skin, and then you take a scanner and you can scan over that system, and it just checks your blood sugar instantly. So for those people that maybe just have, you know, some kind of cognitive deficit or manual deficits, thinking like outside the box and considering CGMs or other strategies to check their blood sugars. And then bariatric surgery, that's kind of a different issue. I think most people that have bariatric surgeries have to do rigorous screening and preoperative psychological counseling, and so they're already linked into a network, but making sure that, you know, they have after surgery follow-up as well, I think is important. And they also have hypoglycemia. They can develop hypo and hyperglycemia after their bariatric surgery, so being aware of that too. You can go on to the next one, Kate. So prevention or delay of type 2 diabetes, so at least annual monitoring for the development of diabetes in those with pre-diabetes is suggested. Or earlier, you know, earlier than annual if there's significant weight gain or steroids or, you know, anything that clinically warrants an earlier test. Patients with prediabetes should be referred to intensive behavioral lifestyle intervention programs. So, you know, dietitian, talking about diet and exercise. And I think we talked about the exercise recommendations a little bit earlier. I'm not sure, I forget if we talked about our food plate method yet, but if we haven't, that should be coming up. You can go on, Kate. Thank you. So pharmacologic interventions to prevent type 2. So metformin therapy should be considered to prevent the onset of overt diabetes. Long-term use of metformin can be associated with B12 deficiency. And the guideline from the ADA just says, as you can see, periodic measurement. For me personally, in my practice, I never really found a good evidence-based guideline on that timeline. So I do 1 year B12 levels in patients that are on metformin, especially in patients that have anemia or peripheral neuropathy where you have a higher suspicion of B12 deficiency. You can go on to the next one. So these are the different agents that can be used. Metformin, the alpha-glucosidase inhibitors, orlistat. People don't really like those as much, like orlistat, because it can cause flatulence and bloating. The GLP-1 receptor agonists, I love those. I use those. I probably use metformin the most, and then I use the GLP-1s probably next in line, and then your TZDs, your thiazolidine diones. So they've all been shown to decrease progression to overt diabetes in patients that have pre-diabetes. So remember, pre-diabetes is our A1C that's 5.7 to 6.4, or it's a fasting blood sugar of 100 to 125 on 2 different occasions. And metformin has the strongest evidence-based and longest-term safety out of all of those. But the reason why I really like GLP-1s, and that's like your Victoza or liraglutide, or the newer ones are called Trulicity or Ozempic. I like those a lot because they have really good weight loss profiles. They have multiple different effects besides diabetes, you know, A1C lowering. So the weight loss effect, and they also can affect neurotransmitters in the brain. They can affect early satiety, so they feel more full, and it helps insulin release and decrease glucose production. So I really like the GLP-1 class. I just wanted to take a break for a second and see if you guys, did you want to go through the case that you have? Is the physician here that wanted to present?
Dr. Woodard, would you like to present your case now?